Hi everyone, I'm Dr. Roman and I am a blood and cancer doctor, and today we are going to talk about diffuse large B-cell lymphoma. Now, whether you are a patient, family member, or a healthcare provider, I think you will find this video extremely educational, and I am going to do my best to simplify it as much as possible because diffuse large B-cell lymphoma is a very difficult topic to understand, let alone explain. So let's get into it. Now, as with all of my videos, this is for educational purposes only. I am not providing medical advice. Now, before we begin, both of these videos are within my channel. The video on the left is titled Intro to Lymphomas, which I highly recommend that you see this video, where I discuss the details about lymphomas in general, including the staging of lymphomas. For example, how is it that we determine how advanced your lymphoma is? And I also recommend that you see the video on the right, which is where I discuss the treatment of diffuse large B-cell lymphoma. So let's start off with a basic overview of everything we are going to cover in this video. For example, we're going to talk about lymphomas, also just facts about diffuse large B-cell lymphoma, the more common presenting symptoms patients have. Also, how is it that we establish a diagnosis? For example, we're going to cover morphology, immunophenotyping, FISH testing. In other words, all the different tests that the pathologist performs to establish a diagnosis and also give us prognostic information. Very important. We're going to go over what's called double expressor lymphomas, double hit lymphomas, cell of origin testing. We're also going to put all of this together and talk about prognosis. And that's important because a lot of patients ask me, doctor, why is it that some patients are cured and some patients are not? Well, we are going to cover this in this video, so very important. We are also going to talk about something that is called IPI. This stands for your International Prognostic Index, which is another sort of scoring system which also gives us prognostic information. And then we will conclude talking briefly about PET scans, which are very important when it comes to lymphoma treatment and response to therapy. All right, now this slide to me is extremely important because right now this should be foreign to you. These are two different pathology specimens or pathology reports of actual patients with a diffuse large B-cell lymphoma. And if you read these right now, this should be pretty foreign to you. In other words, unless you're a healthcare provider, you read this, this is likely to be another language. Well, what if I tell you that if you pay attention in this video, towards the end, you will be able to interpret these pathology reports and understand them. And if you think that is not the case, then you know what? Accept my challenge. Watch this video and I guarantee you will understand it, because at the end of the video, I'm going to refer back to these two pathology reports and we are going to go over them in detail. So if you have had a biopsy, find your pathology report so you can follow along. All right, so the first thing that I want you to understand is that there are many different types of lymphoma. As you can see on this slide here, these are all different types of lymphoma. So can you imagine, a lot of these lymphomas have different treatment plans, different diagnostic tests. So this is one of the reasons that lymphomas are so complicated. So the first thing that you want to make sure is that you have been appropriately diagnosed. That's number one. And what we are going to cover in this video is specifically diffuse large B-cell lymphoma, which constitutes these lymphomas that I have in bold black lettering here. So as you can imagine, look at all of these different types of lymphoma. So question number one, when you see your doctor, is you want to make sure that you have been appropriately diagnosed and that you truly have a diffuse large B-cell lymphoma. All right, now let's move on to diffuse large B-cell lymphoma facts. These are things that I want you to understand about this specific lymphoma. First of all, why is it that some patients are cured and others are not? And as I've already alluded to before, we are going to discuss this in this video. This is the most common lymphoma in general. It constitutes about 40% of all lymphomas, and it is a type of non-Hodgkin's lymphoma. It's slightly more predominant in men compared to women. And this is important. You can have de novo diffuse large B-cell lymphoma or diffuse large B-cell lymphoma from a transformation. Now, let me explain what I mean. Sometimes diffuse large B-cell lymphoma can start off as a diffuse large B-cell lymphoma. You did not have a pre-existing lymphoma. It started new. Okay, that's de novo. Now, sometimes you can have a pre-existing low-grade lymphoma, meaning a lymphoma that grows very slowly, and in due time, it has transformed into a large cell lymphoma or an aggressive lymphoma. The most common finding, or the one I usually see, is, for example, a low-grade follicular lymphoma, which has transformed into an aggressive lymphoma. So that's what I mean here, that your diffuse large B-cell lymphoma can be de novo, meaning it started as a diffuse large B-cell lymphoma, or it can be a transformation from a prior low-grade or slow-growing lymphoma. Now, this is very important, and that is that most lymphomas, including diffuse large B-cell lymphoma, is a potentially curable cancer. Approximately 2/3 of patients have or are cured. And that's very important to keep in mind, because when it comes to treating lymphomas, we usually do not give up on lymphoma patients. Because of this reason, a lot of patients do have a chance of a cure, even if you have advanced disease. So something for you to keep in mind. Okay, so now let's move on to diffuse large B-cell lymphoma symptoms. And these are the symptoms or the complaints that most patients have. Now, the first one is what we call lymphadenopathy. That means that you have a lymph node somewhere in your body that is enlarging. It is growing. And a lot of times patients will tell you that they feel a lymph node growing in their neck or under their armpit, for example. And in due time, it is continuing to grow. Very important. So if that's happening to you, seek medical attention. The next one is what we call B symptoms, B as in boy, and this is seen in about 1/3 of patients. This is very important because these include fever, weight loss, and drenching night sweats. Now, the fever is usually a fever of unknown origin. You know, we evaluate you for an infection, we don't find it. You have these fevers that come and go. Sometimes the fevers are pretty high, and that would be one presenting symptom, the fevers. The weight loss is usually unintentional. So it's a patient that'll tell you, doctor, I do not know why I'm losing weight. I'm not exercising, or I'm not, having any special diets, and I continue to lose weight. That's another B symptom. And the third one are drenching night sweats. And it's important that you keep in mind that we all sweat at night. That's normal. But the word here is drenching night sweats. And patients will tell you exactly that they wake up and their clothing, whatever article of clothing they have on, is soaked with sweat. Okay, and that's what we usually see. So if you have any of these, then you are deemed to have a B symptom. It's very important because these symptoms also have prognostic information. All right. The next one is central nervous system symptoms. This is if you have lymphoma in your brain, or you have lymphoma within your cerebral spinal fluid, where you can have blurry vision, or issues with coordination, or weakness in one hand compared to the other, depending on where it is in your central nervous system. You can have CNS type symptoms. Also a testicular mass. I've seen that a few times, especially an older person that has a testicular mass, or a mass anywhere in your body for that matter. It could suggest that you have lymphoma. Also pain, of course, as with any cancer. If you have tumor pressing up against a nerve root or pushing up against an organ, this can cause pain. And there are other symptoms that patients present with, but by far, the lymph nodes and the B symptoms are the ones that I usually see in my clinical practice. All right, now this is very important, and this is the sites of disease. Where is it that I usually see lymphoma? Well, first of all, up to 1/3 of patients have bone marrow involvement. Remember, your bone marrow is what makes your blood cells, your white cells, your hemoglobin, your platelet count. So up to 1/3 of patients with diffuse large B-cell lymphoma will have bone marrow involvement. Got to keep that in mind. Of course, you already know that the lymph nodes are by far the most common site. Okay, so disease within lymph nodes. But sometimes lymphomas can be outside of lymph nodes, and this is what we call extranodal disease. Want you to remember that because I'm going to be referring to this a few times. So if you have extranodal disease, it means that your lymphoma is somewhere else other than your lymph nodes. Now, the GI tract is by far the most common, for example, the stomach, sometimes the colon, but anywhere within your intestinal tract, you can develop lymphoma. You can also develop it in almost any organ, your testicles, bone, thyroid, salivary glands, tonsils, skin, liver, breast, adrenal glands, kidneys, your vagina, cervix. I mean, lymphoma can start and grow anywhere. So that's why it's very important that whenever they tell you you have a mass or you have a tumor somewhere, they have to exclude the possibility of a lymphoma. All right, now the workup. So if you have been diagnosed with a lymphoma or they think you might have a lymphoma, the first thing that you're going to want to do is have a thorough physical exam. You want to examine the patient head to toe, looking for lymph nodes. Does the person have a palpable spleen? Do they have a palpable liver? You want to look at the skin because remember, lymphoma can also involve the skin. So you want to thoroughly examine the patient. Then you want to move on to blood tests. For example, a CBC, which is your complete blood cell count. I already told you lymphoma can involve your bone marrow in up to 1/3 of cases. So if you start having, if you're a person with a diffuse large B-cell lymphoma and you have anemia or a low white blood cell count or a low platelet count, it might suggest that you have bone marrow involvement by your lymphoma. Also, your complete metabolic panel, this is looking at your kidney function, liver function, your electrolytes. I mean, you want to make sure your organs are functioning appropriately. The next one is an LDH, and this is an important one. LDH stands for lactate dehydrogenase. This is a cheap blood test, but it gives us some information. And what I want you to learn by your LDH is that usually, not always, but usually, if you have an aggressive lymphoma growing in your body, a lot of times your LDH will increase. So that's something that I want you to keep in mind. Also, uric acid, and I'm going to refer to uric acid when you watch my video on the treatment of diffuse large B-cell lymphoma because uric acid is very important. Now, the other test that we are going to want to perform is some sort of a picture of your body. We want to know, where is it that you have lymphoma? This is what we call staging. Okay, staging is very important. Now, a PET CT scan is preferred. This is the number one test because lymphomas light up big time on a PET scan. A PET scan uses a fluorescent molecule together with sugar, and wherever you have lymphoma, that lymphoma will eat up that sugar and it will light up. It will light up like a light bulb and you will see it on a PET scan. And that provides, of course, a lot of valuable information because it'll tell us, are you a stage 1, 2, 3, or 4 diffuse large B-cell lymphoma? Very important. Now, if you cannot have, or if they do not have a PET CT scan where you live, then the next best test will be a CT scan of the chest, abdomen, and pelvis with IV contrast to try to find exactly where you have lymphoma. The next test, this is a blood test. We want to evaluate you for hepatitis B virus, evaluating the hepatitis B surface antigen and the anti-hepatitis B core antibody. The reason for this, when it comes to treatment, one of the medications that we use, if you have hepatitis B in your body, this treatment can reactivate the virus and can cause harm. So we want to make sure you do not have chronic hepatitis B. Also, an echocardiogram or a MUGA scan. This is to evaluate your heart function, just to make sure that your heart is strong enough to tolerate some of the treatments that we provide. Pregnancy testing, of course, because before we treat you, we want to make sure you're not pregnant. Also, you can consider some additional tests. This includes HIV testing, hepatitis C virus testing, a lumbar puncture. If you're a person that might have central nervous system lymphoma, like we discussed on a prior slide, then maybe a lumbar puncture would be another test to perform. Also, an MRI scan of the brain could let us know if, for example, they find a mass in your head or in your brain. So very important test to consider under that scenario. I already went over a possible bone marrow biopsy. Now, I can tell you that a bone marrow biopsy Since the lymphoma may involve your bone marrow in up to a third of cases, sometimes your doctor may want to perform a bone marrow biopsy. But the good news is that PET scans, once again, PET scans are so good that a lot of times it will tell us if your bone marrow is involved or not. It'll light up. So if your PET scan did not light up in your bone area or your bone marrow area, most of the times you will not have bone marrow involvement. So nowadays, with the PET scans and how sensitive they are, a lot of times we do not perform bone marrow biopsies, but there are times that we do. So something for you to discuss with your doctor. And obviously, if you are of childbirth age, or you want to have a child later on in life, before you have treatment, consider fertility preservation. All right, now diagnosis. How is it that we establish a diagnosis? Well, first of all, most patients will present with an enlarging lymph node, or they will have B symptoms, and then we perform some sort of an imaging test and it finds a mass somewhere in their body. So now the next step is we want to confirm the diagnosis, right? And there's a saying in oncology, and it goes, when tumor is the rumor, tissue is the issue. We want to obtain a biopsy and look at it under the microscope. Because remember, you can have cancer, but there are many different types of cancer. Carcinoma, lymphoma, sarcoma, and the list goes on and on and on. And if you have a lymphoma, already demonstrated that there are many different types of lymphoma. So this obviously requires tissue. We want to take a sample and look at it under the microscope. All right. Now, the problem with lymphoma is that a lot of times we need to look at the architecture of a lymph node. Okay, it's very difficult to establish a lymphoma diagnosis without looking at a pretty good sample size, right? And in this, we're going to evaluate the morphology. In other words, the pathologist will look at it under the microscope and basically tell us what they see, describe the finding, the morphology of the lymphoma. Also, we will perform other ancillary tests like immunohistochemistry, flow cytometry, FISH testing, which stands for fluorescent in situ hybridization, molecular testing, chromosomal testing. There's a whole bunch of tests that the pathologist will perform to try to diagnose, is it a lymphoma? And if it is, which lymphoma do you have? So obviously, the reason I'm telling you this is that you need an adequate sample size. A little piece of tissue is not going to be good enough, right? So now, when you obtain a biopsy, usually there's one of three ways. Number one is through an FNA, which means they're going to put a little needle, a tiny needle, and just take a few cancer cells. The next test is a core needle biopsy, where they use a slightly bigger needle and they take a small, tiny piece of tissue, an actual piece of tissue, not just cancer cells. And the third option is what we call an excisional lymph node biopsy, where you will go to surgery, usually outpatient, and they will remove an actual whole lymph node. So if you have a lymph node in your neck, they'll make a little incision and pluck out a whole lymph node. So when it comes to FNA, I can tell you from my own experience, it's almost never enough to make a diagnosis. I find it a waste of time. The next possibility we already went over is the core needle biopsy. Remember, a slightly bigger needle. It might give a diagnosis, but a lot of times it's also not enough. And that leaves us with the third option, which is the excisional lymph node biopsy, actually removing a whole lymph node. And I can tell you, usually that is the way to go. So something for you to discuss with your doctor. But when we're thinking lymphoma, I almost always push for an excisional lymph node biopsy. Now, when it comes to morphology, meaning what does the pathologist see under the microscope, and we're talking about diffuse large B-cell lymphoma, they will usually see medium to large sized lymphocytes or cells. Remember, this is why it's called a diffuse large B-cell lymphoma, because you have B cells that are larger in size than your normal B cell. Okay, so that's what the pathologist will usually see under the microscope, and it gets their brain thinking, you know what, this looks like a lymphoma because these are lymphocytes, these are B cells, and they're larger in size, all right? All right, now, once you had that biopsy and you have good sample, now they'll take another piece of that tissue and they will do what's called immunophenotyping. This is another type of test to try to identify what proteins does this tumor have. because that will give us two things. It'll give us diagnostic information to make sure that, yes, you have a diffuse large B-cell lymphoma, but it also gives us prognostic information. So very important. It gives us two things here. Now, you can obtain immunophenotyping by either immunohistochemistry or flow cytometry, and sometimes both. It all depends what your pathologist thinks is necessary at that time. All right, so it's very simple. They will perform these tests and they will tell us if these proteins are there or not. Now, for example, let's break these down. CD30 is one of them. So CD30 is expressed in about 15% of diffuse large B-cell lymphoma patients. So either you have it or you do not, and this is associated with a more favorable disease. So you see, if you have CD30, if your lymphoma expresses CD30, that's favorable, right? Now, another one is BCL2. It's expressed in about 60% of diffuse large B-cell lymphoma. And if your tumor expresses this, this is not good. This is inferior prognosis. The next one is BCL6. And if you have this, which is expressed in about 75% of cases, this is better. CD10 is expressed in about 40%, and this is good. MUM1 IRF4 is expressed in about 50% of cases, and this is bad. This is inferior. Ki67 is basically tells you how quickly is your lymphoma growing. The higher your Ki67, it usually means that your lymphoma is growing faster. So it is usually greater than 40%, but it is occasionally even greater than 90%. And of course, the higher the number, it just means that your lymphoma is that much more aggressive. MYC is another one, MYC, and it is expressed in about 40% of diffuse large B-cell lymphoma cases. And if you have it, that's inferior. And CD5 is another one. It's expressed in about 10% of cases. And if you have it, it's associated with more aggressive disease and a worse prognosis. So this testing gives us a lot of information. Again, we usually see these in diffuse large B-cell lymphomas. Some patients may have one of them, may have multiple of them. So it helps us in establishing a diagnosis. And depending on which one you have, it could also give us prognostic information, as we just went over. All right, now this is very confusing, but I'm going to simplify it. And believe me, you will understand it and you will be glad you did. And this is the difference between expression and rearrangement. Very important. Now, expression is looking for a protein. Does your lymphoma have a certain protein? Yes or no? And this is performed by immunohistochemistry. This is the test that they use. The next one is, does your tumor, your diffuse large B-cell lymphoma, have a rearrangement? This means that it has a chromosomal abnormality, in this case, a chromosomal translocation. And this is performed by FISH. Remember the FISH test, fluorescent in situ hybridization. So I want you to keep this in mind. Expression means that your tumor has a specific protein, whereas rearrangement means it has a chromosomal translocation. It's a chromosomal event, very different. All right, now let's get into it. There are three proteins that we are going to look at, and these include BCL2, BCL6, and MYC. When you are talking about expression, looking for the protein, you can have the BCL2 protein, so you will be said to have BCL2 expression. Again, this is not good. BCL2 is not good, inferior survival, and it is seen in about 55% of diffuse large B-cell lymphoma patients. Now, BCL2 rearrangement, again, this is done by FISH, looking for the chromosomal translocation. And the chromosomal translocation is a 14-18 translocation. This one is seen in about 20% of diffuse large B-cell lymphoma cases. If you only have this BCL2 rearrangement, it has less prognostic significance. Now, the next one that we look at is BCL6. If you have the protein, meaning you have expression, That's better. That's a better prognostic finding. And that is seen in about 75% of diffuse large B-cell lymphoma patients. Now, the other one is BCL6 rearrangement, the BCL6 chromosomal abnormality. And this has unclear prognostic significance, and we see this in about 30% of cases. And the last one here is the MYC. Either if you have the MYC protein, meaning you have MYC expression, that's not good, and it is seen in about 40% of cases. And if you have the MYC rearrangement, the MYC chromosomal abnormality detected by FISH, this is also not good, and this is seen in about 10% of cases. All right, so going back to the original question, why is it that we cure some patients and other patients we do not? Well, it has a lot to do with the prior slide. Remember all the different CD markers, the Ki67. It's common sense that if you have some or you have others, then you can have either a better prognosis or an inferior prognosis. Same thing here. If you have BCL2 expression or MYC expression, if you have them, you will have a worse prognosis than if you do not have them. Now, we're going to get into something important, so I want you to remember this. Okay, the BCL2, BCL6, and MYC expression versus rearrangement. All right, now keeping that in mind, we're going to go over two possibilities here, and this is a double expressor lymphoma versus a double hit lymphoma. Extremely important. The first one is double expressor lymphoma. Remember, expressor. Expressor means that it has the protein. Again, looking at MYC and BCL2. So if you have the MYC protein and you have the BCL2 protein, okay, you're expressing both of them, then you are called a double expressor lymphoma. This is seen in about 25% of cases where you have both proteins at the same time in the same disease. Okay, BCL6 is not important in this discussion. And if you have this, if you are a double expressor lymphoma, you have an intermediate prognosis. So that is so-so. That's not that good. All right. Now, moving on to a double hit lymphoma. In this case, we want to look at your rearrangement. And here, if you have the MYC rearrangement, meaning the MYC chromosomal abnormality, and you have the BCL2 chromosomal translocation, you have both of them, you have both rearrangements. All right, this is not good. This is what we call a double hit lymphoma. Now, the other one is a MYC rearrangement and a BCL6 rearrangement. Now, you already know BCL6 is not as bad as BCL2. So if you have rearrangements of both of these, then you are said to have an intermediate prognosis. All right. And these are both seen in about 5% of cases. So when you have a diffuse large B-cell lymphoma, you can be either a double expressor diffuse large B-cell lymphoma or a double hit diffuse large B-cell lymphoma, or have neither one, right? So that's another thing that you should look at your pathology report to see if you fall under, or which one of these three categories you fall under. All right, now before we continue, I'm sure you are feeling overwhelmed, but don't be. Believe me, in the next few slides, I'm going to tie all of this in and it will make sense to you. And remember, I'm going to break down those two pathology examples at the beginning. And believe me, when I go over that, you will understand all of this. All right. Now, another way that we can obtain prognostic information is by determining cell of origin. Very important. Notice how all of these tests give us prognostic information, as well as it helps us establish a diagnosis. All right. Once again, it goes back to that original question. Why do some patients do well, meaning we cure them, whereas other patients might relapse and we unfortunately do not cure them? Again, it has to do with all of this. So if you have lymphoma, you really want to know all of this information. So just to break this down as far as cell of origin, if you can envision this, we already know that diffuse large B-cell lymphoma is a cancer of your B lymphocytes. Now, B cells, okay, they want to grow and mature. So when you have your most primitive or earliest form of B cell, it will start to grow and mature until it becomes a mature B cell. Well, obviously, if you have a lymphoma, it's because something within that maturation process, something went wrong. There was a DNA change, damage that provoked the lymphoma to begin. All right, so now, depending on where that damage occurred, that will give us information that we call cell of origin testing. So just reading the definition, cell of origin testing is to determine the stage of B cell development where the malignant transformation occurred. And again, this will give us a lot of information. Now, we determine this by one of two ways. Right? These are just the tests that we can perform. One is immunohistochemistry, and the other one is called gene expression profiling. That's it. So one of these two tests will be performed, and it will tell us cell of origin. So the first one, okay, and it happens to be the most common, is what we call germinal center B cell, or GCB. So if you look at your pathology report, it might say that you have a germinal center B cell lymphoma. All right. Now, this means that you have BCL6, EZH2, CD10, and LMO2. This one is seen in about 60% of cases. And why is this important? Well, because if you have a germinal center, it is better. It carries a better prognosis. Now, the other possibility is what we call an activated B cell, or ABC for short. And this simply means that when they perform these tests, you have an XBP1 and an IRF4 MUM1 finding. And this is seen in 30% of cases, and this one carries a worse prognosis. So here's another test that by determining the cell of origin, it also provides prognostic information. Now, obviously, there are times where performing all these tests, we do not know if you're a germinal center or an activated, and in this case, you are deemed to have unclassifiable, which is seen in about 10% of cases. And in this case, we deem this to be of an intermediate prognosis. Now, I'll tell you what I usually see in clinical practice. A lot of times, they will call it either germinal center or non-germinal center. So germinal center is telling you simply that you have a GCB, so the germinal center type. But if they say that you have a non-germinal center, it simply means that you're one of these two, either the ABC or the unclassifiable, because a lot of times they'll just clump those two together. So what I want you to look at on your pathology report is, if you had this testing done, cell of origin testing, do you have a germinal center or do you have a non-germinal center? Very important. All right, now as promised, let's do a little recap where we will tie everything in together. Going back to answer that original question, why is it that some patients do better than others? Right, here you go. So first of all, you already know that if you only have disease in a lymph node, that is better than if you have it within an organ, what we call extranodal disease. For example, testicular lymphoma or lymphoma within your central nervous system, right? So that's one reason. Obviously, the earlier stage you are, the better. So if you're stage 1 and or 2, it's better than if you have stage 3 or 4 lymphoma. It makes sense. The more lymphoma you have in your body, the worse you tend to do. The next one is what we call bulky disease. And this simply means that you have a lymph node or a mass of lymphoma within your body that is very large in size. Usually the magic number is 7.5 centimeters or greater. And this makes sense. The larger a ball or a mass within your body, the worse off that tends to be. All right. Now, what is good? Well, remember with all the testing we did, if your lymphoma has CD30 or CD10 or BCL6 expression, that is better. Those are favorable. If it has CD5, MYC expression, BCL2 expression, MUM1, IRF4, that is inferior. See, so we start adding, putting all these together, and then at the end, we have a clearer picture if a patient is going to do better or we do not expect them to do as well. Another one is, are they a double expressor lymphoma or not? Are they a double hit lymphoma? Remember, do they have rearrangements of the c-MYC and the BCL2, That's another very important prognostic finding that gives a poorer prognosis. Are they germinal center versus a non-germinal center? Okay, so again, you put all these together and you obtain somewhat of a clear picture as to what do you think is going to happen. Is this person going to have a good chance at being cured, or do we think that they are not going to do as well? And keeping that in mind, maybe we will be more aggressive in treating this patient. All right, now we're going to go over the International Prognostic Index. It's called the IPI, and this also gives us added prognostic information. And for this, we are going to look at 5 parameters. Number 1 is your age, either you're greater than 60 or less than 60. Your serum LDH, remember the blood test, the LDH, it's either normal or if it's high. Your performance status, which is what we call your ECOG performance status, is how strong are you? If you're a performance status of 0, it means that you are asymptomatic, you're doing well, you can perform your activities of daily living. If you're a performance status of 1, it means that you have symptoms, but you still function normally. You do everything that you normally do on your day-to-day routine. A performance status of 2 means that you have a lot of symptoms, but you spend more than 50% of the day out of bed, meaning more than 50% of the day you are functional. A performance status of 3 means that you are very symptomatic, and unfortunately, due to this, you spend more than 50% of the day either sitting down or in bed. And a performance status of 4 means that you are bedridden or chair bound. Very important. So we will determine your performance status, and if you are a performance status of 2 or more, then that's a point. Also, if you're clinical stage 3 or 4, that's another point. And if you have more than 1 extranodal site of disease. All right, so you're going to add up whatever points you have in your specific case, and this will give us information. All right, so you're going to have 1 point is given for each, and the score can possibly be from 0 all the way to 5. Now, this will estimate your 5-year overall survival and progression-free survival. So, for example, you are considered low risk if you only have 0 to 1, a score of 0 to 1, and here is said that you have an overall survival of 88% with a progression-free survival of 81%. If you have a score of 2, you are low intermediate risk with an overall survival of 76 with a progression-free survival of 67. If you have 3 points, you're high intermediate risk, overall survival of 67 and a progression-free survival of 58. And if you have 4 to 5 points, you are high risk and you have an overall survival or 5-year overall survival of 54% and progression-free survival of 46%. So here's another way or another type of test that gives us prognostic information. Now, I do want to tell you that in my opinion, the numbers nowadays are slightly better than this because we have newer treatments that have become available. So, something for you to keep in mind, and all the more reason for you to be very compliant with your doctor, because in my day-to-day practice, I'm actually seeing numbers that are slightly better than this because of these newer treatment options. Now, PET scan, and we're almost done. But I think it's very important that we discuss PET scans. Just know that, again, the PET scan works by a glucose molecule or sugar molecule together with a fluorescent molecule. And wherever you have cancer, and I'm keeping it simple here, very simple explanation. Wherever you have cancer, it will eat it up and it will light up. All right? So this is what we call SUV. The SUV, the higher your SUV, the higher the uptake on the scan. That's all that means. Now, it's very important that you understand that a PET scan is a picture. It's not a biopsy. Many different things can give you a positive PET scan. For example, cancer, of course, can light up on a PET, but so can inflammation. So can an infection. So a positive PET scan does not mean you have cancer. We usually still need a biopsy to confirm this. Now, of course, if you already had a biopsy done and it demonstrates a lymphoma, for example, and it's lighting up on many areas, then you can safely say that, yes, this is the lymphoma that is lighting up on the PET scan, all right? So this is why the PET scan is so important. Now, when it comes to cancer, specifically, since we're on the topic of lymphoma, the Deauville score is very important, right? Now, your radiologist, when they read the PET scan, if they see that it's a lymphoma, they should give a Deauville score. Very important. And it's a 5-point scale where they will give you either a score of 1, 2, 3, 4, or 5. Just know that 1, 2, and 3 means your PET scan is negative. It's good. A Deauville of 4 and 5 are considered positive. That means that unfortunately they are seeing something there. All right, now why do we use a PET scan? Well, usually 2 reasons. Number 1, to stage you. We want to know how advanced is your lymphoma. And also, and I want you to remember this, assess response to therapy. If you can envision this, you have a PET scan done initially, it lights up. Now we're going to give you treatment, and we can obtain another PET scan and compare it to the first PET scan to see how good are you responding to treatment. So in other words, we're using it to assess response to therapy. And this is very important that you remember this, especially when you watch my video on the treatment of diffuse large B-cell lymphoma. Now, once again, find this video where I discuss staging. If you want to figure out if you're a stage 1, 2, 3, or 4 lymphoma, I go over it in this video. Now, as I promised, let's go over this pathology. The top of these are 2 different pathology specimens. These are from actual patients. So let's start off with the one on the top. So this is a person that had an axillary lymph node biopsy, right? So right there, it's telling you that it's within a lymph node. So that's good. I put here green is good, and then red will be unfavorable, all right, or not good. So in green, it's an axillary lymph node. That is good. You already know here it's a diffuse large B-cell lymphoma. All right, so that's how you know that that's what your diagnosis is. Notice that this one is germinal center type. So you already know germinal center is better than non-germinal center. Let's continue reading here, and then it'll tell you to see comment, or on comment, immunohistochemical stains or studies. This is, again, the type of test that they use. Revealed that the lymphoma cells are positive for CD20. CD20 is a B-cell marker. So again, in keeping with this is a B-cell lymphoma. This one has CD10 and BCL6. If you remember, those are good. Those are favorable. While negative for pankeratin, CD5, and BCL2. Remember, CD5 and BCL2 are unfavorable. So the fact that these are negative is good. It also has a Ki67 of 40%, which is high, but it can be even higher than 90%. So for being a diffuse large B-cell lymphoma, it's not as high as some other cases that I have seen. Now, the FISH studies, again, remember, double hit. You want to make sure it's not that. FISH studies for c-MYC, BCL2, and BCL6 rearrangements reveal that they are negative. So in other words, this person is not a double hit lymphoma. Now, the reason we know it's not a double expressor is because BCL2 is negative, right? It does not express the BCL2 protein. So in this case, this is a regular diffuse large B-cell lymphoma, germinal center type, non-double expressor and non-double hit with a Ka67 of 40%. Awesome. Now, let's go to the next case here. This person has a colon mass biopsy. So it's already telling you this is extranodal. This biopsy was not from a lymph node. And you already know extranodal is not favorable. It's telling you that it is a diffuse large B-cell lymphoma. All right, so that establishes the diagnosis. This one is germinal center, so that's favorable. Now let's read the comment. Immunohistochemical studies reveal that the lymphoma is positive for CD20, again, telling you it's a B-cell lymphoma, CD5 and BCL2. So these are positive in this case. And you already know CD5 and BCL2 are not favorable. While negative for pankeratin, CD10, CD30, and BCL6. Remember, all 3 of these are favorable. In this person, in this case, they're all negative. So that is not good. And the Ka67 is 90%, very high. So again, it's in keeping with the fact that this lymphoma is an aggressive, rapidly growing lymphoma. And when we move on to the FISH studies for the rearrangements, remember the MYC, BCL2, and BCL6, notice that in this case, it is positive For the c-MYC and BCL2 rearrangement, meaning that it does have those chromosomal translocations, meaning this is consistent with a double hit lymphoma. Again, you can see in this particular case, unfortunately, we're dealing with a patient that has an illness that is a lot more aggressive. So when we come up with a treatment plan, we want to be or consider being much more aggressive with the patient on the bottom than, say, the patient on the top. All right? Now, I highly recommend that you find this video within my channel where we go over the treatment of your diffuse large B-cell lymphoma. Now, remember to like, share, subscribe to my channel, and drop a comment. Let me know what you think. Is there something that I could have done on this video to simplify it even further for you? So all the best, and I'll see you on the treatment video.